Okay, are we ready to go? Great. So
Yep.
welcome everyone. I'm Dr. Eric Arzubi, child psychiatrist based out of based out of Billings, Montana, and collaborate with Mountain Pacific Quality Health on this series. And I am part of Frontier Psychiatry and all virtual practice here in Montana. Today we are here in clinic number 3 of our series focused on child psychiatry. And we'll be reviewing mood disorders in youth today. What I would like, if it's all right with you, I would very much like if you guys could, using the chat function, 2 things. One is, send me your, tell me your name, what you do, and where you are, because you guys are all shy and turn off the camera. One day we're going to figure out a way to turn the cameras on without your permission. It'll be interesting. And then the other thing, tell me what I'd like to know from you guys. What are you interested in knowing about, or what are you curious about? What do you wonder about when it comes to pediatric mood disorders? Okay, so again, pediatric mood disorders, that's what we're reviewing today. I'd like to hear from you. What are you interested in learning about? What kind of things come up for you when we talk about this? Let's see, looks like it's, yep, we have a couple people in the waiting room, but it looks like they're coming in. Great. All right. So let me see. All right, let me get you guys all chatting. All right, so name, role, and location, and then tell me what you're wondering about. What would you like to know about pediatric mood disorders? Thank you, Tiffany. Thanks for kicking us off. Oh boy, I'm not going to pronounce it again this time. I get once was good, but adults, moving more requests. Yeah, adolescents. Yeah, that makes sense. Cool. Home visiting nurse Bozeman. Love to know more about parents can support their children when children experience mood disorders. Yep, great point. And I think one of the things about yeah, actually, you know what? This will be good. So yeah, please keep these things coming in. Let me just set the stage. So again, today is right the third in the series of presentations on child psychiatry, and a couple kind of basic things I'm going to try to keep hitting on every time we meet. Okay, number one is think about what you're most likely to see based on epidemiology. What do I mean by that? What's the most common thing you're likely to see? Now, if you remember, and I'm going to show you some statistics, but if you remember the most common pediatric psychiatric diagnosis in the first 17 years of life are anxiety disorders. They're anxiety disorders, right? So if you find a group of 100 youth age 0 to 17, the most likely thing you're going to see, the highest percentage of diagnoses would be anxiety disorders. Number 2, behavioral disorders, including ADHD, cognitive disorder, opposition defiant disorder. Number 3 would be mood disorders, which include depression and bipolar disorder. Number 4 would be substance use disorders. So again, so I want you again remember what are you most likely to see? A random person comes in, again, anxiety number 1, number 2, behavioral disorders, number 3, mood disorder, number 4, substance use disorders. All right, so now let's take a look at the presentation. I'll share that here. Let's see. Okay. All right, so here's a slideshow. All right, do you see the full slide?
I do.
Great. All right, so again, child psychiatry clinic, pediatric mood disorders. So again, these are all slides that'll be shared with you, but these are important statistics that I want to keep highlighting, and I'll try to highlight as often as we can, because it's important to know what you're likely to see. So again, keep in mind, and actually I should have done this in a little bit of a different order, but nevertheless, here's something you'll see, right? So These first two up here are mood disorders, right? What are the two basic mood disorders you're going to see? There's unipolar depression, right, or major depressive disorder, and there's bipolar depression. And look at the total. Look at the total lifetime prevalence. So this is the total lifetime prevalence across males and females before the age of 18. Okay, so 12% of youth will have met criteria for major depressive disorder by the time they turn 18. Only 3% bipolar disorder. So again, you've heard me say this before, and I'll say it again: is bipolar disorder is rare, and so you're not likely to see that very much. Depressive disorder, obviously, right, 3 to 4 times more common than unipolar depression. So, and the prevalence of any mood disorder in youth is 14.3% across males and females. And here you get some data on, the relative prevalence between females and males. And just for review, here you have anxiety disorders. So any anxiety disorder, look at this: females before the age of 18, likely to 38% are likely to have met criteria for an anxiety disorder. 26% males, and then all in 32%. So a full third of youth will have met criteria for an anxiety disorder before turning 18. And these are kind of some of the, these are some of the common ones, right? So generalized anxiety disorder, social phobia, and specific phobia. And these are actually the most frequently seen ones are actually specific phobias and social phobias. Here, I put in ADHD, which is the most commonly seen sort of quote unquote behavioral disorder. And keep in mind, these are using DSM-4 criteria. So a little bit different in terms of naming of the disease, or at least where they fit in the DSM. But again, you're looking at, 13% of males, 4.2% of females, and a total of almost 9% will have met criteria for ADHD. And for any behavioral disorder, you're looking at 20%. And again, behavioral disorders include ADHD, conduct disorder, and oppositional defiant disorder. Next, any substance use disorder. They break it down in alcohol and then illicit drugs, but just for simplicity's sake, I'm just throwing this in here. So again, any substance use disorder, 11.4% are likely to will met criteria for substance use disorder before age 18. And then any class of psychiatric diagnosis, 50% of youth will have met criteria for a psychiatric diagnosis before turning 18. So again, remember, anxiety 1, behavioral disorders 2, anxiety disorders 1, behavioral disorders are number 2, and then mood disorders number 3. So again, anxiety, behavior, mood, and then substance. All right. And again, I'm here. You'll see me I'm still remaining a little bit big picture because I want to set context for you guys all the time. Is when you're doing an evaluation of a child, keep in mind they don't. I was going to say they don't live on an island, but clearly they do in Hawaii and other places. But they don't live alone on an island. They live with family. They're part of a community, they're part of a family, they're part of a school system, they're part of these different systems, right? So it's important to know that context is key. So when you do an evaluation of a child, and I know I'm stating the obvious, but I guess I'm just going to remind us, is you got to keep in mind what systems they're part of, because a lot of times, and I would say a large, vast majority of times, you're going to see a problem with a system they're involved in. So it's not just a child disorder, but I would tell you it's and this is what I say to families. I said I never seen where it's a child only problem. I've always seen that there's a family system problem in one way or another. So again, not just in isolation. So remember, consider the family dynamics. Consider the presence of psychiatric disorders in the parent or the guardian. Clear research supporting the fact that if you're treating the youth and their psychiatric diagnoses, but the parents can continue to struggle with their own mental illness, you're going to have a harder time taking care of the child. And then ACEs, right? And if we remember ACEs, right, adverse childhood experiences, there are 10 of those. There are, again, just to review what they are, there are 3 forms of abuse, right? So there's emotional, physical, and sexual abuse, 2 forms of neglect, physical and emotional neglect, and then 5 forms of family dysfunction, including parental separation, mental illness in the family, domestic violence against mom, incarcerated family member, and family member with a substance use problem. Next, school system. What's going on in the school system? How's a child doing in school? Remember last time we talked about learning disabilities. They are often underdiagnosed or undiagnosed. And then, is the child a victim or a perpetrator of bullying? These are real issues, obviously, that are faced by kids who go to school. And we know that both victims and perpetrators of bullying are more likely to be struggling with a psychiatric problem. And then lastly, these other kind of factors like food or housing insecurity, and then substance or alcohol use in the child, right? So again, context is key. So again, in the interest of looking at the big picture, I also wanted to share with you guys some screening tools that if you're looking for things and you're trying to do an evaluation, a comprehensive evaluation of a child, there are actually some there are again these free measures you can see, and actually you just pull online. If you Google DSM-5 cross-cutting symptom measure, this will pop up for you. So this right here is a cross-cutting symptom measure for kids age 11 to 17. So these are self-report. They have another one that is reported by the adult. The reason I like this is you see these Roman numerals here on the left. These are different domains that are being screened for. So for example, here, number one, Roman numeral number 1. Have you been bothered by stomach aches, headaches, or other aches and pains? Are you worried about your health or about getting sick? Right. So this is looking at somatic symptoms and anything related to somatic disorders. Roman numeral 2, been bothered by not being able to fall asleep, stay asleep, or by waking up too early, right? Sleep problems. Roman numeral 3, been bothered by not being able to pay attention when you were in class or doing homework or reading a book or playing a game, ADHD. Roman numeral 4 talks about anhedonia, sadness, and depression. So this is depression. Roman numeral 5 and 6, irritability, more annoyed, angry or lost temper, right? These behavioral disturbance. Roman numeral 7, started lots of more projects than usual, done more risky things than usual. So here now we're screening for bipolar, for mania. And here slept less than usual, but still had a lot of energy. Again, mania. Down here is anxiety. Here's psychosis. Here obsessive thoughts. Here's substance use, and here's suicidality. So again, this is nice. It's free. It's based on the DSM. And what's nice is, so this is a level 1 cross-cutting symptom measure. Then they have a level 2, which is this one. It's basically like the PHQ-9 with a few other items thrown in, but this is sort of the level 2 that is used from the same list of measures and from the DSM-5. And this depression one is the original name of this questionnaire was here, that's PROMIS, emotional distress, but it asks about feeling sad, feeling alone, feeling like everything in my life went wrong, like I couldn't do anything right, I felt lonely, sad, unhappy. So these are all different elements of and signs and symptoms of pediatric and adolescent depression. And then certainly you can use a PHQ-9A, which is the patient health questionnaire for adolescents in youth age 11 to 17. And so again, these go through the 9 criteria of depression. They assign a score to each one based on severity, right? 0, 1, 2, or 3. and then you add them all up, and then you can figure out you can figure out the severity, right? So 0 to 4 points, not clinically significant. You have mild, moderate. I have no idea what moderate severe means versus severe, but anyway, here they split up into 4 different levels of acuity. I don't like that. In my mind, it's like mild, moderate, or severe. But this is what you see here. And so remember last time, and again, I told you about the great resource, which is the care guides from the University of Washington PALS program. And this is where this algorithm comes from. So again, just going through this very basically, child shows up with depressive symptoms. You want to do, again, some safety screening, and remember some of the things we kind of alluded to before, so is there neglect or abuse? Is there a medical condition, right? Like low energy could come from anemia or problems with thyroid. And then you want to make sure you address safety concerns. So are there thoughts of hurting oneself? And if yes, are there plans or available means, right? So there's risk safety. Thinking about comorbidity. So here, you have a whole bunch of them that are likely to coexist with depression, anxiety, opposition defiant disorder, conduct disorder, ADHD, dysthymia, substance abuse. And then you can take a look at the diagnostic criteria and see if it makes sense. And then you can go to the next decision point and find out, can it be managed by primary care depending on the severity? You can refer. If not, you can start treatment. And again, splitting this up into mild, moderate, severe. On the mild side, a lot of times with mild depression, you can treat this without medications. And a lot of it is, psychoeducation, which basically means teaching the patient and the family about what is depression. Is it something that lasts forever? Does it go away? What does an episode look like? What are the different treatments? What are the impact of depression on functioning? And so here you go, right? Educating patient and family. So you want to support peer interactions, get people moving, behavioral activation, exercise, sleep. Sleep is critical, right? And sleep is something, gosh, I would say almost every single, I would say in the vast majority of psychiatric disorders, sleep is a problem, right? So targeting sleep as a way to promote recovery and healing, critical. So reducing stressors when possible, removing any guns from the home, offering the parent and child further reading resources so they can educate themselves, setting up a follow-up appointment in 2 to 4 weeks to check in. Again, this is somebody with mild depression. Repeat rating scales down the road to see how things, if the numbers are changing in the PHQ-9A. And again, if they don't improve, they're candidates that you can refer. Next, if you're looking at moderate to severe, that's when you want to look at combination therapy, like psychotherapy plus medications. When and if available, the 2 sort of indicated psychotherapy modalities are cognitive behavioral therapy and IPT, which is interpersonal psychotherapy. Certainly psychoeducation, coping skills, problem solving, just like we mentioned before for mild depression. You want to educate the patient and family. Family therapy referral, again, remembering context and recognizing that, I would wonder, are mom or dad depressed and how is that affecting things at home? And, what's going on with the family system and family dynamics. So if you're looking at moderate to severe, but especially severe, that's when you want to consider starting an SSRI, which stands for selective serotonin reuptake inhibitor, which, really are kind of your commonly known antidepressants. So fluoxetine is the most widely studied when it comes to depression. It's a first-line choice. So fluoxetine also is Prozac. And then second line are escitalopram or Lexapro and sertraline or Zoloft. Third line agents are other SSRIs or bupropion or mirtazapine. So you want to wait 4 weeks between dose increases to see if there are any changes, right? So keeping in mind that usually takes 6 to 8 weeks of a full dose to really make a difference. You also want to watch out. some of these SSRIs, especially sertraline, I've seen that causes sort of what I call activation, or what's called activation, which is a sort of restless anxiety. And so that can happen, especially if you move up doses too quickly. Let's see, and those are, so those are the key sort of recommendations. Again, fluoxetine or Prozac is number one. Number two, so the second line would be Lexapro, Zoloft, also known as escitalopram and sertraline. Mania. So why am I talking about mania? So remember, there are two types of mood disorders. There's unipolar depression and bipolar depression. The only way to diagnose bipolar disorder, is to have the presence of mania. So if a person has never had a manic episode, they don't have bipolar disorder, period. Again, the patient has never had mania in their life, they just don't have bipolar disorder. And again, irritability is not mania. Mood swings are not mania. Remember, a manic episode has to last either 7 days to be a full-blown manic episode, or 4 days if it's a hypomanic episode. So unless you have a full hypomanic or full manic episode, there is no bipolar disorder. Again, too often, and I think people are getting better, but I've seen too often where folks identify someone with a lot of irritability or kind of these fast mood swings, and they say, oh my God, bipolar disorder. That's just not true. The other thing is, I am really suspicious if anybody diagnosed bipolar disorder before the age of 16. And I think I may have said this before. In the last, in my 9 years in Billings, Montana, I may have diagnosed bipolar disorder in a youth maybe 5 times, and I've seen thousands upon thousands of patients. Again, it's not as common as is thought, or at least is commonly believed. Here's a mania scale that is, again, in the level 2 of the screening process. So remember, you have that level 1 is that cross-cutting symptom measures. Then if you identify possible depression, then you can use that screening tool I showed you before. If it screens positive for mania, here are the kind of the self-rating scale for mania. So number 5, obviously, are kind of the more, so 1 is low likelihood of manic symptom, 5 is higher likelihood of manic symptom. So here this one says, I feel happier, or I should say, or more cheerful than usual all of the time. Here it says, I feel extremely self-confident all of the time. Question 3, I can go all day and all night without any sleep and still not feel tired. Number 4, I talk constantly and cannot be interrupted. And then question number 5, I am constantly more active or on the go all the time. Right, so those give you, right, somebody checks off 5 for all these, you're looking at very likely manic episode. In terms of treating bipolar disorder, so again, look at this algorithm. Again, this is from the PALS program. If you are considering bipolar disorder, this next box says, hang on a sec, think about some other diagnoses before you go there, right? ADHD, conduct disorder, oppositional defiant disorder, major depression, early abuse or neglect in dysregulation syndromes, difficult temperament of child plus interpersonal conflicts, autism spectrum disorder, OCD, medical cause of mania. So again, look at all these kind of rule outs or differential diagnoses they're asking you to please consider before calling it bipolar disorder. Next, you go for a safety check and ask about suicidality, drug abuse, and then ongoing neglect or abuse in the home. And then when it comes to diagnosing, right, again, you're double checking. Does the child have a history of clear manic episode for greater than 4 days? Is there a history of hospitalization for mania? And the reason, unless someone it's hard to call something a full manic episode without someone more often than not seeking out a higher level of care. Like if I don't know if anybody has witnessed or talked to someone who's had a full manic episode, but it's not something that you they'll kind of just go away with no problem. Like if it's a full manic episode that leads to bipolar 1 disorder diagnosis, often hospitalization and emergency room visit is in the picture. Next question, is there a history of psychosis or severe suicidality as part of that presentation? Was there euphoria or grandiosity? And then again, using a scale like the child mania rating scale, the young mania rating scale, or the one I just showed you, to kind of track progress and track the symptoms. And then, it mentions here on the right, if you're seeing that it's a likely diagnosis of bipolar disorder, then you should be referring to a specialist to evaluate or treat for bipolar 1 or bipolar 2 disorder. And here,
Dr. Arzubi.
Yep.
We have a question in the chat box.
Okay, what do you got?
What about when there is a strong family history of bipolar and the child presents with depression, but does not respond well after adequate trial and becomes increasingly irritable with antidepressant use?
Mm-hmm. Yep. So great question. So again, taking a good family history, critical. And again, the things I wonder about are the age. So again, if my thinking is different, if it's a 10-year-old versus a 17-year-old. So again, a 17-year-old, I'm thinking bipolar is a possibility. 10-year-old, I probably won't go there. Certainly not at age 10. I'd certainly not treat it. Then the other thing is, I wonder the adequate trials again, and I believe you when you say adequate trials. I always just keeping in mind that the medication adherence is, especially in psychiatric populations, is pretty low. So I want to be super sure that we got a full dose, because again, sometimes what happens in primary care settings, antidepressants are underdosed. So people, there's some pediatricians might stop at 10 or 15 milligrams for Prozac, right? But you really want to be looking at 40 or 60 milligrams of Prozac. Zoloft, same thing, and others. So again, I would just I would go back and make triple sure that all those were kind of adequate trials. And then I would go through and say, okay, those antidepressants didn't work. Now there's ongoing irritability. And I wonder at that point, are there other stressors in the picture? Anything going on at home, anything else that can be kind of causing the irritability? Are there other diagnoses? Like anxiety can present as irritability too, right? We know that there you have the fight or flight response in people with anxiety. People can get pretty violent with anxiety. So you hear what I'm doing, right? I'm trying to check every single box before I actually go to bipolar disorder. So in my mind, it's a diagnosis of last resort, especially in youth. And then at that point, depending on the irritability and what I'm treating, then I can start considering other medications for sure. But again, I will not diagnose bipolar disorder unless I've seen a manic episode. Even if I'm seeing irritability, and even if they have a strong family history, I will not diagnose bipolar disorder until I see a manic episode. The other thing that's happened, as you know, is in the DSM-5, they created a new diagnosis called disruptive mood dysregulation disorder, which is essentially somebody with a lot of irritability a lot of the time. And part of the reason they did that and created that diagnosis was kind of for the reason you're asking this question is, well, gosh, we have nothing else. Doesn't seem like pure depression. You have this family history, so DMDD often is being used as a diagnosis. Next, fluoxetine and escitalopram are FDA approved for use in kids 8 and 12 years old, respectively. If fluoxetine is not working, do you use sertraline or escitalopram second-line therapy? So great question. As we know, I think, let me see if, did I put this in? Oh yeah, let me show you guys something. I'm going to show you guys something and I'm going to go back to that question. Just so happens we're about to, again, I'm kind of giving you I'm giving you a lot of big picture stuff today. Look at, there's a great book I have on psychopharmacology in youth. And I thought I'd kind of share this with you. It's a nice table, a nice summary of all the meds that are approved for youth, right? So these are all the ADHD medications, right? So you have the Ritalin families. They have methylphenidate and dexmethylphenidate, which is basically Ritalin and Focalin. Amphetamines, which is basically your Adderall family. Lisdexamphetamine is Vyvanse, right? So look at this. Adderall is FDA approved all the way down to 3 years old. I don't know that I've ever given Adderall to a 3-year-old, but it's approved all the way down to 3. Atomoxetine or Strattera, clonidine, guanfacine. So all these are 6 and up. Next, here we have antidepressants. So to your point, here we got fluoxetine, FDA approved for depression in 8-year-olds. Sertraline, interestingly, right? Check this out. The only 2 medications that are FDA approved for depression in kids, fluoxetine and Lexapro or escitalopram. Not even sertraline is, but we do know it's an SSRI. It works similar to fluoxetine and escitalopram. It's well tolerated in kids, so that's why it's considered a second-line medication. The other thing we like about fluoxetine, and there's actually some debate about if this is a reason actually fluoxetine did better than other medications in research, is fluoxetine has a really long half-life, which means it stays in the blood a long time, which means if a child is having a hard time still taking the medication every single day, or they skip it here and there, it's not as big of a deal as it is if you were to miss sertraline or escitalopram. In other words, sertraline and escitalopram are have shorter half-lives, stay in the system less time, and so are more affected by problems with missing doses. So back to the question. If somebody has depression, again, I start fluoxetine. If that doesn't work, I don't have a strong preference between sertraline or escitalopram. Sertraline, I know, has really nice support in the use for anxiety disorder. So if somebody has both anxiety and depression, I might go with sertraline. But again, I've also had some kids have really good luck with escitalopram. So I won't pick one over the other. It really depends on if there's kind of comorbid anxiety. That's where I go with that. But as you know, I mean, FDA. So just real quick, these FDA approvals, right? These are medications with FDA approved uses in kids for psychiatric disorders. Look over here. Look at this, Haldol, and this is not widely known, but if you look it up, if you look up Haldol and look at FDA approved uses, look what it includes. It includes psychosis, Tourette's, hyperactivity, severe behavioral problems, and explosive hyperexcitability. I mean, that's FDA approval from years ago. So they used to use this actually for ADHD back in the day. Now, do I go to Haldol for ADHD? No. So again, even though the FDA has done some approving of things, you don't always want to necessarily go right to what the FDA, right? Because it's leftover stuff, right? So you always kind of have to balance what the FDA approvals with kind of what research tells you. Risperidone, you'll see, is approved for 3 different things: schizophrenia, bipolar disorder, and irritability and autism. Quetiapine, Seroquel, schizophrenia and bipolar disorder. And then you have aripiprazole or Abilify, is approved for 3 different uses. Olanzapine, approved for 2 different uses. Asenapine, lithium, and so those are all kind of the medications. So that was my little tour of FDA approved medications. The book is this one. It's Clinical Manual of Child and Adolescent Psychopharmacology. Clinical Manual of Child and Adolescent Psychopharmacology, edited by Dr. Robert Findling, Findling. Great book. So there we go. The other thing I guess I probably should have emphasized, the other thing I should have emphasized is treating mania is easier than treating bipolar depression. Treating mania is easier than treating bipolar depression. When somebody's in an acute manic state, you can give them a pretty strong antipsychotic, and it'll calm down the mania. But when someone is struggling with bipolar depression, not unipolar depression, again, bipolar depression, it's a different animal. And in adults, lamotrigine or Lamictal can be a good medication for bipolar depression. There's less evidence for that, for use of Lamictal in kids. So in kids, what you want to look at for bipolar depression is probably lurasidone, there's lithium, and then quetiapine or Seroquel. Next question, is there ever a time you would use the PSC17 or DSM? No, they both work fine. They both work fine. The PSC17 is a nice general screening tool, a pediatric symptom checklist. So I would use what you feel most comfortable with. You know, these are tools you can have in your toolbox, and I would go with what works for you and you're most comfortable with. Part of what I wanted to do by showing that these cross-cutting symptom measures are just to show you that there are these other free tools out there that you can use and that can help you with, right? Because it's hard to kind of keep all these symptoms in your mind, and the more you can kind of standardize your approach, the more likely you are to kind of catch the right diagnosis and be able to monitor symptoms as well. So, any other questions? And also, I guess I'd wonder if there are any clinical questions or cases. Could you describe more? Okay, what would a mania episode or manic episode look like in a child adolescent? And we'll go up to, describe more about differential diagnosis of DMDD with other disorders. Okay, so I'll start off with a manic episode. Manic episode, again, if we're looking at the definition of manic episode, I would stick with the actual criteria. So again, they include, and actually what I'll do is, let me see, I can pull up, let me go ahead and pull up the DSM. That'll be just easier to kind of go through the exact criteria with you. If I can find it, I have my little, I'm not very smart. I didn't, I thought I'd download it in this phone. So we'll go over, again, the cardinal symptoms of a manic episode. Again, there is flight of ideas, right, or racing thoughts, pressured speech. There is increased risk-taking, right? Doing, and what's critical in the definition of a manic episode, because sometimes people struggle with defining a manic episode in adults as well. So I want to be very clear. There's, right, and no, so the slides are off. So everybody goes through ups and downs, right? We all have mood swings. Now, when you're trying to define, but just because we have mood swings doesn't mean we have bipolar disorder. And right, so if we were to chart our moods, kind of this up and down, we all have these up and downs. Sometimes we have longer downs or we have longer ups. What's different about a manic episode is you have these normal ups and downs, but a manic episode is a spike that stays up there and then drops back to normal baseline. So when I ask about manic episode, I try to be very clear and say, during this time, right, when you're talking about they might have pressured speech, flight of ideas, energy more than is typical. What I'm asking them is, I'm talking about this is different from who you normally are. This is different from who you normally are. Because again, we all have these ups and downs. But if what they're describing is like, oh yeah, I have more energy, that tends to happen every few days and it lasts about, maybe one day. That's not it. it has to be an episode of time where they are acting very different than who they normally are at baseline. That's a manic episode. So again, it cannot be part of their baseline. So I would use the same criteria I use in adults to identify a manic episode, because indeed that is a manic episode. Then the next question here is differential diagnosis with disruptive mood dysregulation disorder and other disorders. You know, on the differential, because again, what you're identifying in DMDD is this kind of chronic irritability. And I would say 10 years ago, what is now called DMDD is what people used to call, we're likely to call bipolar disorder. Again, but there's no full-blown manic episode. There's this chronic irritability. People didn't know what else to call it, so they bipolar. No, they now give you DMDD. So again, I would use DMDD and bipolar disorder as diagnoses of almost last resort. Of I would rule out. Remember, go back to the list we gave you at the top of the hour, right? What's most common? Most common is anxiety, mood disorder. Sorry, anxiety, behavioral disorder, mood disorder, and substance use disorder. Right? Those are the most common ones. So check those off first, right? Check those off first. Once you've checked those off and it's none of those, then I would start looking more at some things like, is it a manic episode? Is it DMDD? And right, asking yourself, right, this chronic irritability, is there something, there's just something that's fueling that chronic irritability, right? If what's happening, is there bullying every day at school? Is there an abuse and neglect at home? You know, is there something that's driving and fueling that irritability? So, I you know, sometimes even at the American Psychiatric Association and some of these presentations, when you have these researchers really focusing on like a bipolar diagnosis, a DMDD diagnosis, sometimes they forget to zoom back and remember the family and abuse, neglect, and some stuff that's really common. So I'd be really paying attention to that, right? Because you could give somebody you could be the best psychiatric psychopharmacologist in the world, but if you're giving somebody an awesome medication, but they're still being abused or bullied, that's not going to improve their mood. It's just not. Azriel, I have a case to share related to this week, last week. Yep, go ahead, Azriel. Let's talk about your case.
Hey, so this is Azriel. I'm a pediatrician on the Big Island. Thanks for hosting these webinars.
Of course.
I just wanted to share that I had this teenage girl, I think she was about 15, who came in about, I want to say a month ago, and she was transferring care from another clinic. And one of her main concerns, at least from her auntie who was bringing her in, was that she was depressed and not like her normal self and doing terrible in school. And they tried an anti-depressive medicine. I think it was fluoxetine. And she, according to the aunt, got even more depressed and was suicidal, and they stopped it immediately and were really worried about it. So this was kind of the context that I was seeing this patient. And my first thought was, okay, this person has a diagnosis of depression, and what other SSRI am I going to use, et cetera. But then I, kind of decided to do, treat it a little bit more from a fresh start and use screening tools. And she really wasn't meeting criteria for major depression. And so I started thinking about other diagnoses and things that seemed to be a common theme between a lot of her mood and school performance symptoms had to do with concentration. And then even in the office, I saw her, like, when I was talking to her, she would be looking around and seemed to be very distracted very easily. And so, then I gave them the Vanderbilt forms and kind of went down that route. And I ended up diagnosing her with ADHD and starting her on, I think it was methylphenidate. And I just saw her back last week, and they were like, oh my gosh, she's so much better already. Like, this is great. Like, and so it was just, a learning lesson that I wanted to share, that, like, I was really tempted to just plug along with the original diagnosis. But there was some things cluing me in that something else might be going on. And it's just a reminder to myself that like, you always kind of have to start with a fresh start and not have like your biases get in the way.
Hey, thanks for sharing that, man. It's funny. And it's so funny you said the second you started saying teenage female depression, well, you can tell, right? And were you at the last one where we talked about ADHD?
Yeah, I was.
Right. So again, underdiagnosed, underrecognized in girls. And I love that you did that, man. That's awesome. That's awesome, right? Because what I found in teenage girls who are struggling with mood problems, but then you start peeling back a layer or two, their mood problems are related to they feel overwhelmed, they feel dumb, they feel like they get criticized because they're not kind of focused or performing. And so, yeah, they feel like crap because their ADHD is getting in their way of functioning. And so I love that's awesome. Thank you for sharing. I think that's a big win because more often than not, you're right. And most other sort of primary care docs, pediatricians might be like, you know what, fluoxetine didn't work, let's go with Zoloft, and then Wellbutrin, and then the girls still struggle. So thank you for doing that. Man, made my day. Other things, other pearls to share. Again, remember, just for those who weren't there last time, ADHD in girls and teenage girls tend to show up more as inattentive type rather than hyperactive impulsive type. Can present sometimes as people think it's anxiety or depression, which again can very often be comorbid and be perpetuated by untreated ADHD. But what's nice about ADHD is if you identify it, a stimulant can actually address it very quickly, and people will see some pretty significant improvements right away. So it's a nice, I mean, it feels really good because it feels like a big win and like you made a big difference. And also girls, well, anyone with ADHD, but in particular, girls who are who have ADHD are more likely to self-harm and consider suicide. Anything else? Well, cool. Thank you guys for your time. Azrael, thanks for showing your face. It was good to see there are humans, and because I don't know if this is staged by Mountain Pacific and that's just me and all these names. I'm going to assume there are people behind this. I know Azrael's there, but I hope to meet other people at some point. So there, and I'm going to keep giving you crap until I meet you. So there. Oh, Crystal, how you doing? Hey, good. So there are humans. This is awesome. Good. All right, you guys have a great couple weeks. I'll see you next time. And thanks for your time. Yeah.
We have put the evaluation link into the chat, so we would appreciate it if everybody can fill out the evaluation. Thank you.
Cool. Thank you, guys. Take
Thanks,
care.
Dr. Arzubi.
Bye.